My name's Medina Johnson, and I'm Chief Executive of IRIS-I. IRIS began way back in 2007 as a research trial, and what we were setting out to do was to test whether a training and advocacy program in general practices improved the way in which clinicians, GPs, practice nurses, anybody in the general practice team could recognise patients affected by domestic abuse and understand how to best support them. So we started out as a research trial over 3 years, testing out this very simple programme in 2 areas, in Bristol and in Hackney. And we had a clinical lead, a local practicing GP, and an advocate, so a specialist worker based in a frontline violence against women and girls service in both areas. And we tested out our training programme in 12 general practices. And we measured for 12 months the amount of identifications and referrals for patients affected by domestic violence and abuse coming from those 12 practices. We then compared those with the identifications and referrals from 12 control practices, 12 again in Bristol and again in Hackney. And what we found was that in general practices that had the IRIS intervention, that had the training, and that had a direct route to support from an advocate in a specialist service, that female patients were 3 times more likely to be identified and have a record of this in their medical record, and 6 times more likely to be referred in to specialist support. And what we know is that from the specialist support, the women felt safer, their health outcomes, both in terms of physical health and emotional health, they reported as being improved. And they also reported that they were visiting their healthcare practitioners in primary care less frequently. What we know is really important from the findings is that it was having a named contact in a specialist domestic abuse service that the clinicians really valued. So in the Bristol site, for example, I was the named contact. So I was the advocate based in the specialist frontline service, co-delivering the training in the general practices with my GP colleague. And then the clinicians in each of the practices referred their patients directly into me. So the clinicians were able to say, we work with Medina, she works with our practice, why don't I ask her to give you a call and she can talk through what we think might support and help you, and you can talk through what you think you need, where you're at with things, and Medina will work with you to determine what feels right for you at this time and what support would be helpful for you and for your family. The IRIS programme promotes what we call the 5 R's, and we want clinicians to recognise when a patient is affected by domestic violence and abuse, ask and do a risk check around that, to then give an understanding and validating response, offer the patient affected by domestic violence and abuse a referral into specialist support so that she can be supported to talk more about what's going on for her, the options that might be available for her, and what she feels might best help her at the time of the referral. And then the final R is record. We want our clinical colleagues, following a disclosure, following a consultation, to make a record of this in the patient's electronic medical record. Because we know that this is important for lots of reasons. It supports with healthcare, because we know that not every patient will see the same clinician every time. So having an accurate record of disclosures of abuse is really important for continuity of and supportive healthcare. It's also helpful for things like child contact requests, looking back in the medical record. Medical records are often consulted. Things like housing, and if the domestic abuse necessitates a referral into the police or the civil justice system, then very often medical records can be interrogated, and so having a record of consultations and a record of disclosures is very helpful. So we promote this 5R stepped response for clinicians, and we promote having a domestic abuse expert embedded in healthcare. So somebody who meets with patients in the general practices where they're patients and who can support them. During COVID, this has been challenging, and we've now adapted and provided our clinical colleagues with information on how to support patients virtually. So we've issued guidance and supported and trained clinicians on how to best support patients when consulting through a telephone consultation or through a video consultation to make sure that the patients are supported safely, effectively and appropriately, and that the referral pathways are still open to them into accessing the support that they find helpful at the time of the referral.